Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me from a retinal specialist. The patient had multiple retinal detachments and then had silicone oil placed into the eye and developed a cataract. And I was asked to remove this cataract, and the oil plans to be left in the eye. And so this patient has a secluded pupil. I'm going to place iris hooks, and you can see my technique on how I do that, trypan blue. And most importantly, you're going to see that this bubble, this oil, as well as an air bubble when I push the air for the trypan blue, is turning the posterior capsule convex. And so it's pointed towards me, yet it doesn't matter and it doesn't affect me one bit because double chop, cross chop, mechanical fracturing is so effective in these cases. Again, otherwise this would be a high risk for posterior capsule rupture, and you're going to see how double chop, cross chop, and mechanical fracturing shines. So you can see these tiny little bubbles of silicone oil on the corneal endothelium, as well as on the right side you see a bunch of little bubbles on the conjunctiva as well. You see these little tiny little small bubbles of silicone. And now I'm going to use a cotton tip to steady the eye. I'm going to make my first iris hook incision, which is in the sclera, in the subincisional area under my main incision. Second iris hook location, my paracentesis location. The third iris hook. Fourth iris hook. My left side paracentesis incision, and then for the fifth hook. So I like 5 hooks, but one of the hooks is in the sclera subincisionally so that I can retract the iris underneath my incision. This is some intracameral epinephrine, and I'm going to try to separate the iris from the anterior capsule with the fluid. And then this is some dispersive viscoelastic to coat the corneal endothelium and hopefully dilate the pupil, which it doesn't really do a good job for. And then this is the iris hook. I'm placing it into the subincisional scleral incision. And you want to place it through the sclera because you're going to be placing your main incision through the cornea and you don't want them to intersect. Having it underneath the main incision helps reduce the risk for iris prolapse in these small iris cases. And so you see my technique. I like to place it through the incision, holding it with the forceps perpendicular, using the stopper to dial and rotate the hook down, and then grabbing it and cinching it down. It's a very easy technique. Some people think it's cumbersome and would rather use a ring. I think rings are not really the best in general. You don't have as much control. You can titrate the tension on these hooks. And again, when you get really good at this and you do a lot of these, they really don't take that long. And remember, there's always risk when you're using a ring. These little eyelets can get hooked on the iris and you can have trouble. So with this, you have much more control. Yeah, it's more steps. But again, if you have a lot of experience, you can see how quickly and easily I'm placing these hooks. Again, 5 iris hooks. So this is the 5th iris hook. Going to make sure I pull the stopper back. Holding it perpendicular. Pulling the stopper back some more. You can see it's starting to shred a little bit. So again, this hook has been used before. So it breaks apart here, unfortunately. But you're able to grab it and then cinch it down. So again, the iris hooks can be autoclaved, and so this one has already been autoclaved once, and you can see this one broke again. So really, these are supposed to be autoclavable 3 times at least. This has been autoclaved only once, so that is a little bit of a quality control issue, but you can see I'm going to go ahead and try to cinch it down so I can resume with the case. So I'm using trypan blue to paint the anterior capsule surface. Remember, there's viscoelastic in there already. I go ahead and try to push air, but you can see some of that air went underneath the lens, which will pose a potential challenge later on. And so a little bit of a problem. Again, silicone oil is back there. Another reason why this lens is wanting to come anterior. And so the bubble ended up being completely worthless. And so I'm going to use the cannula just to paint the anterior capsule surface. You want to use the cannula almost like a paint roller, just being mindful you're dabbing down. You're not pushing down. You're not wanting to put any traction on the capsular bag and on the anterior capsule as you do this. Pushing the trypan blue out with the dispersive viscoelastic, and this is the triplanar corneal incision. I make a vertical groove, turn the eye away from me, place the blade into the deep part of the groove tunnel, and then I enter. Again, very controlled. Again, I could have put in that last hook after making my incision, but it's okay either way. And these are the sharp tip Haldane-Perkar forceps. I'm going to turn this teeth sideways, point it down, and then I'm going to be able to puncture because these have a sharp tip to it. You can see there's some zonulopathy as I'm pushing down. And you can see again the convex nature of the anterior capsule. You want to be real mindful of radialization forces here. And of course, you don't want to have a Argentinian flag. This is a little bit different from an intumescent lens, but nonetheless, there is some posterior pressure, namely due to that silicone oil in the vitreous space. So again, I'm pretty well controlled, not having trouble at all with the rhexis here. Finish off the rhexis, burp some viscoelastic out. And this is a Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice way of lift the lens up so it can decompress the bag. Nice. You saw some bubbles come out because there's some bubbles again hiding in the vitreous space. Again, those bubbles started when I tried to put the bubble in for the trypan blue. You see all those silicone oil bubbles coming into the anterior chamber as well. Sweeping underneath the left side and then the right side, and then the lens begins to spin. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. And I'm going to go bevel up now. Again, this is a dense lens. I don't want to have a complication, and I want to be able to debulk this lens, especially since there's essentially very little anterior chamber because of the silicone oil pushing the lens up. So I'm going to go ahead and sculpt a central trough. I went to the dense lens setting. This is a fairly dense lens. And I'm going to go ahead and just continue to sculpt, primarily debulking the central core, and then we're going to go ahead and perform the terminal chop technique. Again, once I'm ready and grooved, a fairly deep groove. Again, you don't have to go all the way down to the posterior capsule with this technique. I'm going to turn bevel back up, place the chopper under the rhexis edge contra-incisionally, just like I do with the double chop, but instead I'm going to be fracturing from the terminal side, keeping that phaco tip deep in that groove. Fracturing from the terminal side allows a full propagation of the tear through and through the posterior lens, and this essentially overcomes and bypasses the posterior plate phenomenon, placing the chopper around the right heminucleus, hooking the peripheral lens, and crushing the right heminucleus in half. Placing the chopper around that first quadrant, crushing the lens with another cross-chop maneuver completely in half, lifting that first fragment up with some vacuum, and then crushing it with mechanical forces, and then emulsifying the lens piece. Placing the chopper around that second fragment, crushing it between the instruments, and then crushing it into smaller and smaller pieces, and then emulsifying the lens pieces. Loosening up that second quadrant, placing the chopper around the lens, hooking the peripheral lens, performing another cross-chop maneuver, fracturing the lens completely in half, using some vacuum to grab it, and then crushing it between the instruments with mechanical fracturing forces, and then emulsifying the lens pieces. Getting around this fragment with the chopper again, performing another cross-chop maneuver. By doing it this way, you're always hooking the peripheral lens with the chopper, bringing the lens towards the center, and then crushing it with opposing forces with the phaco tip. Again, the phaco tip is acting like a chopping block. Turning that second heminucleus in front of me, you can see that oil coming out. Again, it's kind of a wild situation. Placing the chopper around the lens, hooking the peripheral lens, placing the phaco tip deep within the bag, you get a full bisecting fracture force. and the lens is now into third and fourth quadrants, placing the chopper around that third quadrant. I don't get a good chop, get around it one more time, making sure it's a deeper chop and then a more effective chop because you're chopping it with better directed opposing forces, crushing the lens in half, using some vacuum to hold that lens on the tip, and then getting around it with a chopper, crushing it into smaller and smaller pieces, and then emulsifying the lens piece. Doing the same thing, crushing the lens into smaller and smaller pieces, using some vacuum to hold the lens on the tip, and then getting around it with a chopper, crushing it into smaller pieces, and then emulsifying the lens piece. This is the last quadrant. I'm turning it in front of me, placing the chopper around the lens, hooking it from the periphery, holding the chopper deep in the bag, getting opposing forces, fracturing it completely in half. Again, all of these fractured maneuvers have 0 ultrasonic energy and 0 vacuum. Go back and look. I never use ultrasonic energy or vacuum at all during the fracturing step of the case. Therefore, this is much more safe, less chance for wound burn, less chance for posterior capsule rupture, less chance for post-occlusion surge and damaging something. And so I'm able to, again, hook the chopper around the lens, crushing it between the instruments, and then crushing it into smaller and smaller pieces, and then emulsifying the lens pieces. Again, very controlled. I have less CDE use. And more importantly, because that posterior capsule is trying to come up at me, because I'm using sparing amounts of ultrasonic energy and vacuum and strategic amounts of ultrasonic energy and vacuum, even though that posterior capsule is coming straight up at me in a convex configuration due to that silicone oil and bubble, I'm able to, again, strategic on and off placement of the foot pedal, modulation, and then I'm able to get rid of the entire lens completely. You can see how convex that posterior capsule is. So I take the chopper out, push BSS in, take the phaco tip out. You see that air bubble is kind of pooching forward. Again, with the collapse of the chamber, there's a lot more air bubble coming forward. You can see, again, exacerbating that convexity of the posterior capsule. I go in with the INA handpiece, and you can see again how convex the posterior capsule is. So I go straight to polish mode because I want to be as safe as possible. Again, these cases have weak zonules. Any case that's been post-vitrectomized, retinal detachment, obviously these patients probably have high axial myopia, again, which those tend to be associated with weak zonules anyways. And then on top of that, you have this silicone oil in the eye as well as an air bubble. Again, there's extreme convexity to the posterior capsule. Again, it's really, really augmented and clearly seen during the INA here, but because of the polymer tip, I have exquisite confidence and control. I'm not going to rupture the posterior capsule. I'm using polish mode and Cortex mode and modulating the 2 steps in order to remove the remaining cortical material that's stuck in the capsule fornix. Again, extreme confidence that I'm going to have an excellent case. And even though the posterior capsule is coming straight up at me from the oil and the bubble, I have very little fear or worry. I've already gotten the lens out completely. The capsular bag is intact. My anterior capsulorhexis is intact as well. I'm just being careful about removing the lens material here, the cortical material. I'm in that polish mode, and I'm making sure that I get, again, a nice cleaning of the posterior capsule here. Go ahead and pulsing BSS into the subincisional capsule fornix, which looks fairly clean. And then this is cohesive viscoelastic to push the posterior capsule down. I turn irrigation off. And I'm pushing as best as I can the posterior capsule back, but you can see there's quite a bit of OVD coming out of the wound. I'm going to go ahead and use a sweep to polish under the rhexis edge of any lens epithelial cells and any potential lens material, cortical material in the capsule fornix if there is any. So far, it's a nice and clean bag. Again, you see that giant air bubble that's away from me. And again, that air bubble is from when I tried to inject the air for the trypan blue. Widening the incision. Again, I like to put a 3-piece lens in these cases when I know there's going to be some zonulopathy. Placing the injector in and then pushing more viscoelastic. You saw some viscoelastic come out. Pushing some more viscoelastic again, making sure that that bag is fully inflated, making sure the leading haptic goes into the bag. This is not a situation you want to accidentally have the haptic popping into the sulcus. This is going to be very difficult to position that lens because that bag wants to collapse. Again, due to the convexity of the posterior capsule from the oil and the bubble. Dialing the trailing haptic into the bag. And again, you might say to yourself, why in the world is that air in the posterior segment? Well, obviously there's some defects in the zonule somewhere that cause that air bubble to go into the posterior segment. As you can see, this iris hook was broken. So I'll go ahead and remove the stopper, and very carefully I'm going to try to twist it with my forceps, getting it in a planar configuration, then it pops out. Obviously, I'm not going to be able to reuse these. Grabbing proximal, pulling the stopper back, pushing the hook down, disengaging the tip off the pupillary edge, rotating it 90 degrees, rotating it towards the open end of the hook. That's right, just like that. Oh, yeah, that one's also kind of broken up. But once you turn it, it then disengages from the incision and then it comes out. That happened because my incision is rather long. And of course, I like to have a long incision, which allows it to be sealed much more effectively. But that is kind of a side effect of having a long paracentesis incision. Again, disengaging the hook off the pupillary edge by pulling the stopper back, rotating it so it's off it, and then rotating it 90 degrees towards the open end of the hook, and it pops out. Again, grabbing it proximally on the iris hook, pulling the stopper back, disengaging the hook off the pupillary edge, rotating it 90 degrees away from the open end, and it pops out. And this is the last one. This is the subincisional one. Disengaging the stopper, disengaging the hook from the pupillary edge, rotating it 90 degrees once again, and it pops out. Okay, so now all the iris hooks are out. I go in with irrigation off, activate irrigation, quickly get underneath the lens, removing the viscoelastic from within the bag. Look at that posterior capsule. It's so bowed up convexly. It's like with the irrigation fluid, it looks like ripples in the ocean. Look at the waves. Look at the waviness with the irrigation fluid that's happening here. It's absolutely wild. And that's, again, from that silicone oil pushing the posterior capsule up towards me throughout the entire case. Go ahead into visco mode, removing all the viscoelastic from the anterior chamber. You can see now the iris is coming down. I'm sure this is going to be a floppy iris. There's still a giant air bubble in the posterior segment. I'm not going to go after that, of course, but that air bubble will dissolve, as all air bubbles do eventually after surgery. I'm collapsing the chamber, trying to make sure I don't get iris to the wound. So I'm turning the irrigation off, pushing BSS to fill up the chamber quickly, and then hydrating my incisions. Again, you can see that giant air bubble in the posterior segment is pushing the IOL anteriorly. So I'm quickly trying to reform the chamber, hydrating my incisions. It pushes the air bubble back. Like I said, the air bubble will dissolve in a matter of a few days, and I go ahead and hydrate my incisions, and that's the end of the case. So again, you can see secluded pupil, the patient was status post-retinal detachment, repair multiple times, silicone oils in the eye, you had a secluded pupil. I was able to retract the pupil using my iris hook technique. Again, 5 hooks, one of which is subincisional in the sclera. Again, it retracts the subincisional iris, so it reduces the risk for iris to the wound and damage to the iris tissue, a much controlled way of doing it. You can see how I used the stopper to manipulate the hook. And again, a very easy technique on doing that maneuver. And then I tried to put an air bubble in, which ended up being counterproductive and actually went into the vitreous space and pushed the posterior capsule further anterior, in addition to the silicone oil doing the same thing. And then I performed double chop, cross chop mechanical fracturing techniques. Again, because I'm using mechanical forces and I'm not using high vacuum or ultrasonic energy, the risk of grabbing the posterior capsule and getting posterior capsule rupture is much lower in these cases. Again, this whole lens is trying to come anteriorly, the posterior capsule is coming anteriorly, but because I'm using sparing amounts of ultrasonic energy and vacuum and strategic use of ultrasonic energy and vacuum, and primarily depending upon fracturing forces to crush the lens into smaller and smaller pieces, and then only pulsing ultrasonic energy and vacuum when I need to, and shielding the posterior capsule when I'm emulsifying the lens pieces, you can see, even though this is an extremely challenging case and a high risk for posterior capsule rupture, this case was rendered a routine case for me. Again, using the polymer tip, you saw during IA how convex that posterior capsule was, but because of the polymer tip, everything went very smoothly. I put a 3-piece lens into the capsular bag, and this patient did very, very well. And again, another classic example, a great example of why double chop, cross chop, mechanical fracturing concepts and principles, in my opinion, are far superior and a much easier way to disassemble the lens in challenging situations. So I hope this was helpful to you, and I thank you for your attention.